Thank you, Heather Evans, Dr. Heather Evans, for talking to us today about wearable computing technologies and their role in surgery.
Sure, it's my pleasure to join you. Thank you for inviting me.
So what's going on? What is Google Glass all about?
Well, Google Glass is a wearable computer, and wearable computers are not new. They've been around for some time, but what's different about Google Glass is that it has the power of Google and Google Now and all the Google suite of apps behind it. And I think what makes that very special for us as healthcare providers is that we suddenly have the power of the internet and a camera and a video camera and a recorder and a hands-free device at our disposal that we can use when we're providing patient care or when we're teaching residents or when we're doing something that maybe we haven't done before and we need some help. And I think it's a very exciting time to be able to use this device, and I'm really excited to talk about it today.
Oh, absolutely. I didn't realize that they were in use in other places. You said that it's been around for a while. Where else have they been in use?
Well, wearable computing is not new, but Google just came out with Glass really since about June. So my story is that I found online, I think I was on Twitter and I was just lurking as I usually did. I was not very active on Twitter, but I read a lot and I saw that Google had announced a contest and it was called hashtag if I had glass. And the point of the contest was for an applicant to describe what they would do had they the chance to buy the device. And as a trauma surgeon and someone that is an early adopter and really interested in technology, it seemed like a great opportunity. I really didn't think I was going to have a chance of winning the contest, but to my surprise, about a month after I submitted my tweet, I found this tweet in my direct message box saying that I had joined the Glass Explorers program. And there was a wave of users just before the If I Had Glass contest that were allowed to get the device. And those were primarily technology people that had attended Google I/O, which is their annual conference where they announce new technology. And I actually knew somebody that had gotten their glass that way, and he got his about a month before I did. He was the husband of one of my partners here at Harborview, and so I actually got to see what the device would look like even before I picked up my own. And I was so excited about it. It was really a very exciting time. And that was I think that was in late May when he got his, and mine was in June.
Well, I bet Google is pretty excited to have somebody in the medical field that something really meaningful they can use their technology for.
Well, and my application was if I had glass, I would use it so that we could learn more about how to take better care of patients. And I included a link to a BBC video that had been shot. A crew had been following out around an air flight medical crew, and they had landed at their dispatcher's station only to find that their dispatcher himself was having a heart attack. And so the BBC film crew kept rolling, and they were able to capture his resuscitation, his shock, and his recovery. And so I thought this was a great illustration of capturing a critical moment
Right.
in medical care. And so I used that as an example of maybe not something that I would be able to do since I'm not, I don't fly with an air crew and I don't ride with the medics very often, but I have a lot of connections to pre-hospital personnel. And I just thought that that would be a really kind of sexy way to entice maybe the people that were reviewing the applications, see, what the extreme possibility might be.
Absolutely.
But as a surgeon, I also feel like there was a tremendous opportunity for us to use it in the operating room and outside of the operating room when we're training our residents or when we want to use it for telemedicine. I think really the sky is the limit, and there's a lot to be explored, so to speak.
So, how do you imagine it in use, say, 10 years from now for the average surgeon in the operating room?
So 10 years from now, I would hope that we will have gotten to a point with our privacy and security issues that we have currently, that discomfort that we have about sharing information, that we will be able to more freely use devices such as Google Glass and other wearable technology to be able to more freely exchange information to take better care of people. Because I think as providers, it's very critical that we get right place, right time, timely information so we can make the best decisions possible. And right now, I'm sure that your audience is aware that if someone arrives in the emergency department and they're unable to communicate with us for whatever reason, we have no idea what their allergies are. We have no idea what drugs they take. We have no idea what their past medical history is, their past surgical history. And really, it's very difficult to even get some of the information from the scene from when paramedics evaluate the patient because they're so busy caring for the patient. They don't do the kind of documentation that we're able to do when we have a lot of people around when the patient has made it to the hospital. But even in a code situation, it's extremely difficult for a large group of people that work very well together in the hospital to be able to capture all the data that happens as it happens.
Right.
And so I think there are a lot of things that you can imagine where we would be able to continuously record a code, we would be able to continuously record an evaluation of a patient in maybe an environment that didn't have a lot of resources, whether that means, out in front of the hospital when someone needs to be transported inside, or if they're in another country or another state where the resources may not be what they are inside the hospital. So we have a lot of ideas about how we might be able to use this. And I would say in about 10 years, I can't imagine that every paramedic and every surgeon is going to have a device like this to be able to continuously record what they do. And it would be used to be able to review if something could have been done better in the future. It would be used to continually care for that patient and make adjustments in their care as it goes on after that initial event. And I think it also would be helpful in the future if they ever had another medical problem or health issue that needed to be addressed to have that as the record instead of taking the time after an operation to dictate and record what happened. Can you imagine a day where we would actually be recording our op note as we were doing the operation? Certainly, the
Yeah.
level of detail would be extraordinarily better than it is now.
Right. So, see, that's interesting. So you're talking about it's almost like continuity of care to have
Right.
this image from the beginning and transferring all this data. And how about
Yeah.
so I can see its use particularly in your field in trauma where knowing what you missed is important.
Right.
And now I think of myself about the times when I'm in a case where I can use the input of another surgeon and I'm trying to reach somebody and they're trying to put on scrubs, that sort of thing.
Right. Yeah, so I think that this happens quite often to us. And there are small things that you can figure out yourself, and you don't really need to call anyone, and you don't want to bother somebody to come in from home, or if they're in another room doing their own case, you don't want to bother them. And, it's something that you can work out yourself. And I think all of us have appreciated those small moments where we have to make decisions that maybe we're not quite sure about, but we roll with it and the patient is fine and we can make the choices that we need to make. But, there are other times when we confront things that are really difficult, or maybe something that we just haven't seen before, and we're not really sure what our options are, or we're not sure what the best option is to pursue. And I mean, I freely call my partners all the time when I encounter those situations. But, if it's in the middle of the night, or maybe you're somebody that works primarily alone because you're in a resource poor environment, like we have several of our residents that have gone to Alaska to work, and they very much feel like they're on their own for a lot of the work that they do. And I think this would be just an incredible option to be able to call someone that you trust maybe somebody that really knows the particular disease process or situation that you're treating, and to be able to get those expert eyes right on the field. I mean, the thing that's so extraordinary about this device is that you're looking at exactly what my eye sees when I project those images from glass. And I think it's very powerful.
Yeah, so that makes great sense. It's like a live consultation, even mentorship, some an aid for
Absolutely.
that.
There's this idea of intraoperative coaching that is emerging. It's always been that the mentor would either be standing across the table as your assistant and allowing you to develop. I mean, that's certainly been the training model the whole time I've been a surgeon and many, many years before that. But this idea of being able to have some eyes on the situation when they're not even in the room, when they're not even a part of the operation, it's a different kind of coaching, and it's really exciting to think about what we can do. But there's so much to learn about that. How does that work? And we're already starting to do some of these things. When we think about the robotic dual console trainer, where someone I've actually never used the robot, so I'm just speaking from information that my colleagues have given me. But when you sit at the dual console, the teacher can sit at the console and guide the student, and take over if need be, but is just basically there as a guide. And I think that there's some analogy to what we would be dealing with if we were working remotely. Without the ability to actually take over the controls, of course. I think that will be well in the future. But anyway, the last thing I want to say about the coaching aspect is that this is really becoming quite important, particularly in light of the New England Journal article that was published last month. I don't recall who the first author is, but it's John Berkmeyer's group from the University of Michigan, and they asked the Michigan Surgery Collaborative, the Michigan Bariatric Surgery Collaborative. They asked their surgeons to send in their very best video, their very best work from doing a lap gastric bypass. And they then essentially graded each of
Right,
these
right.
videos and
This appeared
looked
where?
at this was at the University of Michigan.
And was this you said it was published recently? I remember
Yes,
reading
it's
about this.
published, I believe it was last month in the New England Journal.
So
And
October 2013. New
yeah,
England.
in
Okay.
2013. And the upshot of the paper is that they were able to grade these videos based on operative length, whether all of the steps of the procedure were completed in a timely
Excessive
and efficient
motion.
way. Right, exactly. Excessive motion, sort of fumbling, if any intraoperative errors were made, what the recovery was like. And then they looked at the outcomes of the patients.
Right.
And of course, it's one of these wonderful studies where you say, well, of course that's the answer. But amazingly, they did find that the surgeons that displayed the most efficient skill had the best outcomes. And I think what this means for us as a profession is that it's time for us to figure out how to all be like those efficient surgeons. And how do we remediate people that haven't gotten there, that haven't honed those skills so that they can be like those efficient and safe surgeons?
Right.
And I think glass is going to be a part of this.
Right.
So I'm really excited to say that one of the authors of that paper just got glass because of me. And we were able to invite a couple of our friends to get the chance to buy glass recently. And Justin Dimmick, who is one of the authors on
Oh,
that
right.
paper, was one of the people that I invited. So I'm
Great.
really hoping that they're able to incorporate the use of glass in the work that they're doing, because it's just going to expand our reach. All of the laparoscopic surgery is fair game. It's low hanging fruit because it's so easy to get those videos. But now we have the capability of doing just about anything
Right.
because glass is so easzy to use.
I think I saw in something that you had written about the use of glass specifically for task training of
Yeah.
residents.
Yeah,
How do you see that?
I think there's a really exciting opportunity for glass in training. And one of the things that I did recently, I gave a talk at the New York eHealth Collaborative Digital Health Conference. This is a conference that happens every year, and it brings together a lot of people from industry primarily, but also physicians and healthcare IT people that are interested in where the technology is going, what are the directions, what's the future. So it's very much a sort of a futurist kind of conference in some ways, and I was invited by Wen Dombrowski, who I met via Twitter, to participate and to present my work with glass so far and how I've been using it as a surgeon. And in preparation for the talk, I got one of my residents who's doing research right now to put together a video with me, just so this is very early, just trying to figure out how we're going to use this, how will it work. And what we did was we set up a Google Hangout, which is essentially a teleconference. But we did it between my resident, Andy, wearing the glass, and me in another room using my laptop. So he put the glass on and he started the hangout, and he was standing in front of a trainer that we use for central line placement. And we use this extensively. Every single surgical resident in our program has to be trained on this trainer before they're allowed to place their first central line in a real patient. So this is not something new for us. This is something we do all the time. And we advocate the use of ultrasound in the placement of the internal jugular central venous catheter.
Is that is that in that Simulab torso that you're talking about?
Yeah,
Yeah.
it's exactly it. It's the trauma man. It's the torso that doesn't have a head and doesn't have any legs or anything. But what it right, and what it does have is it has these sort of the anatomic landmarks of the sternocleidomastoid, the two heads of the sternocleidomastoid, and it has beneath the sort of siliconized skin, it has two tubes that are filled with either red or blue colored saline to represent the carotid and the IJ. And so what we did was Andy placed the ultrasound screen just like you normally would in the same position so that we could see the screen and we could see him looking down at that triangle in the neck. And I'd be happy to share the video with you. It's about 2 minutes long. But essentially, what we watch him do, we decided that placing the entire central line, the whole procedure would probably take too long for anybody to ever really pay attention that long. And we wanted to really focus on using the ultrasound. And that part of the procedure, as you know, is primarily when you're placing the needle in the vein and getting the wire in. So that's the part of the procedure that we focused on. And we set up a scenario where he was calling me and saying, I've done a lot of these, but I'm not really comfortable with the ultrasound. Could you just watch me and tell me if I'm doing everything okay? And I said, absolutely. And so then he goes and shows us with the ultrasound. He's able to demonstrate where the vein is, and we confirm that it's the vein and it's not the artery. And he shows it in this nice longitudinal view, and we can actually see the needle going into the vein on the ultrasound screen, despite the fact that we're, not only is he video capturing the screen, he's transmitting that video from glass to another place through Google Hangout.
Wow.
And you are actually able to see the needle go into the vein. And then as he puts the needle into the vein, he then looks down and you can see him just show that needle in the vein, and he can aspirate the blue saline. And so we just felt like that was a really nice way to show proof of concept that it was possible to do this kind of demonstration, that it was possible to have enough video fidelity and audio fidelity to be able to conduct that kind of observation and coaching, and that we did it in real time, and we just felt really good about it because it was in the sim lab, because we weren't going to be doing anything dangerous to anybody. And I think what we proved to ourselves was that it was really not obtrusive. It was not getting in the way of the procedure at all. It's just like wearing a pair of glasses, in fact. And it was really quite easy, and we were pretty excited when we were able to do that.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.